Thank you, Dr. Loy, and thanks for bringing this wonderful conference in Iowa City. Of course, this is my home turf. So, as Dr. Loy was mentioning about the pain issue, yes, it is challenging. Almost anybody who has come across with a chronic pain component, it is significant. This is my disclosure. I don't have any disclosure except the media disclosure. I had chosen. I'm a pictorial person, so I have chosen several pictures from either textbook, journals, web, whatever the reason, for the education purposes only. So this is my I seen this patient almost 20 years ago. At that time, she was a 19-year-old girl. That's her journey. So she was fluoroscopic at the institute where I was working before. She was presented with diffuse headache and had tried several medications. That's where my interaction was in the beginning. And I don't want to go in that detail too much. Several medications has been tried, several blocks has been tried, Botox injection has been tried, all of them failed. And finally the referral was made and diagnosed with Chiari. Finally she went into decompressive surgery. She had good benefit after the surgery, but some of the headaches are still persisting. But the severity of the headache was better, but some of the characters has changed after that. But still debilitating. Now the pain had moved more in neck and posterior head and involving the temporoparietal area. So she was re-referred, or she just showed up in pain clinic because she was our tech. So she is dealing with us anyway for all the time. So initially her headaches was after the surgery was intermittent, all the similar distribution prior to the surgery as per her. But she developed a new symptom, which is the choking intermittently sensation and hoarseness of voice come out without any reasoning. Suddenly comes and stays there for a few minutes and then goes away. Over the 10-month period after the surgery, her headache became constant, and now it started radiating towards the jaw. So because his occipital tunnel was positive, so we went back to do the occipital nerve block on that ultrasound guide. She had significant benefit, not only for the headaches, but it also relieved those choking and hoarseness voice sensation, and each time for 3-4 months. By third, fourth injection, this duration has been decreased, and it is decreased by now benefit is less than a month, and in the end, I think she only got 7 days benefit. So now we need to look into what to do, because if she was C-arm tech and fluoro tech, so she was using over the head movement quite a bit to move that C-arm. So we had recommended some ergonomic adjustment, and she went through. Initially her symptoms got improved, but again, after some time, these symptoms start aggravating again. At that point, we had suggested the occupational component a change, and she decided after quite a bit of discussion, so she moved to the marketing side, so at least she don't need to use her hand too much above the head, and that had improved the aggravating symptom, but the baseline was persisted. It is significant. At that point, we had talked about the occipital nerve stimulator, and it was placed, and it has significant relief. And these are just cartoons. Oh, sorry. On that. So when we were doing the occipital nerve block, initially we were using both lesser and the greater occipital. Both nerves are blocked. Same thing we have done later on, and which she got great benefit. Because of this short-term benefit, we have put this lead actually on both sides, and she got significant benefit. So that is the one case related with the Chiari, which I just want to share. The story will continue. That was 2004-05, and now we are dealing with later, but I will come back on that. So again, I don't need to tell what is Chiari. Of course, for my purposes and the clinical presentation of Chiari, I'm sure all of you had come across. It's a significantly wide range of presentation, mostly neural. It is, as everybody know in the room, this is structural deformity association. So again, that is so many different mechanisms has been suggested, and the presentation from Dr. Klinger is just before about this, almost same thing about this myelin bridges, along with this atrophy and the scarring of the rectus capitis minor muscle, which attach to this bridges, and when these are not functioning properly, it does not relieve the pressure. In that situation, the reverse pressure happen and Syring's formation happen. Again, this is hypothesis. This is one of the mechanisms which make physiological sense, and that's what again, this is easy to explain, this to talk about. This pictorial paper was published just like a few months ago. So essentially, the symptoms can happen either because of the direct pressure on the neural tissue, or the back pressure built up on this on the CSF flow, which can cause increased intracranial pressure or cause the Syring's formation, and then because of that, and eventually lead to distraction of the neural tissue. Again, whenever symptom develops, they are not single mechanics focused, they are multifactorial. So being a multifactorial component, this is, again, you guys all know the list. My interest is this. I'm sorry, I'm using the different buttons. So my interest is here, but again, and this is what the pain prevalence, irrespective of which paper you read, it is still 69% is pretty significant. And it affects so many different factors, visual, otalgia associated with it, swallowing difficulty. I forgot to put, she also, I'm putting choking here. Also, she has some dysphagia, my patient at that time. And balance disturbances. Again, these are part of the whole syndrome, but I'm more interested in pain in my thing. So one thing is, if anybody has a neural symptom, especially because associated with the structural defect and the progressive pressure effect, only answer is surgical decompression. It is, as per my understanding, seeing so many different patients, that's the final answer eventually anyway. So we, earlier institute where I was, whenever I used to see, when they start getting this pressure component, if the symptoms are presenting and they are progressively including from pain to different aspect of the neural symptoms, they are essentially referred if they are not already seeing a surgeon. So there is no cure, as we already know, of the symptom. Only thing we can improve upon. So, and in that situation, surgery is critical. And I don't need to teach the choir here. Everybody knows about that. So from my perspective, there are two groups of patients I come across. One patients are non-operative symptomatic patients. Other one is the post-operative residual or refractory pain patients. Again, distribution of prevalence of pain is almost same, irrespective of whichever the patient you are talking about. Only thing is this percentages get changed. I see more on the below the cervical area pain, more common with the post-operative component versus the symptomatic non-operative patient. That's only my personal view, but it has not been reported that clearly. Headaches are almost 50% of this pain is associated with the headaches and neck pain. If you put both things together, almost that makes it 70% of the total patient. So again, different mechanisms, different presentation, different associations. For the symptomatic, they are presenting with several reasoning, either intracranial pressure, formation of Syring's, or craniovertebral instability. Again, that's part of that the muscle weakness we were talking about. We had more interest in that particular picture, which I showed. I know for the pain purposes, maybe myoneural bridges needs to be looked into more. But we are more interested in the cranial vertebral instability, so we should not offer the procedures which otherwise can cause more issues. And the post-surgical, either just local surgical issues or the neural damage or musculoskeletal component. This is what most commonly we see, beside other deficit happening because of the surgical lesionings. Again, most common presentation is, we already talked about it. They're characteristically aggravates with Valsalva maneuver. That helps us to understand it is not cervicogenic, especially when we don't have much more clarity. And if there is associated brainstem symptoms with the neural deficit, that's also put us into the understanding of the brainstem association, and that's lead to Chiari. It's a very busy cartoon on that, but the purpose of this is we know in chronic pain, irrespective of whatever it is chronic pain has a decreased gray matter in various parts of the brain, which facilitate reorganization and lead to neuroplasticity. Also, chronic pain associated with the enhanced neural connectivity activity, because so some dormant connections over the evolution, which was not present in normally with the chronic pain, somehow become active. So it enhances afferent neural fibers and the feedback loop mechanism of various aspects of the brain. And that's where chronic pain is almost related with the emotional component. So if we go back into that, so that makes the chronic pain a multifactorial component. And if it's a multifactorial, when there is a non-specific presentation, we don't point the finger to a specific region, and there are associated comorbidities also muddle the picture. Of course, we need to look at the multimodal approach whenever we want to go on the management issue. So this is I'm sure all of you are aware about, this is the newer accepted pain definition. These blue things were there in a little bit similar language, but now they had added on, and I think for the right reason. So, and that itself tells you why it is multifactorial, why chronic pain is complex. It's an unpleasant sensory and emotional experience. They added the footnote, it's a personal experience, not only the learning experience from the society, associated with or resembling, that is the neo addition, with actual or potential tissue damage. Associated with that, they also added on with this new, it's a 2020 accepted definition now. So influenced to varying degree by biological, psychological, and social factor, and through their learned life experiences. So again, as soon as you put, these are sensory component, physical component, biological component, social component, the one factor which left on this discussion on the definition, which was the spiritual component, I can tell you it is discussed very aggressively. I will not be surprised in the next revision that component will be added. That was just taken out by a sliver of the margin, because so maybe in US we don't see that, but across the world, spiritual component is significant in affecting the chronic pain component. So again, that purpose of giving you this information is this, everything which is involved make the chronic pain management for everybody more challenging. So as we talk about, it has to be multimodal, and various different approaches has been used in that. This could be pharmacy, interventional component, surgical, of course, you guys are part of it. Physical therapy is crux in it. We will talk why. Non-pharmacological modalities are there, psychological modalities, lifestyle changes and education support is extremely critical in managing of these symptoms. So when we talk about the pharmacological component in this group of patients, we are talking about three different things. First thing is medication used to decrease intracranial pressure. So at least this is all symptomatic component before the surgical component. We can use the different pharmacy to neuromodulate the symptoms, so you can have altered sensation or altered pain perception on that, or we can block the neurotransmission if we can, which become challenging, especially in Chiari. So again, I don't want to go into too much detail, but there are several medications has been used to decrease the CSF production so thus decreases the intracranial pressure. As a spine surgeon, irrespective of whichever the spine surgery you do, corticosteroid is very commonly used during the even surgery intraoperatively, just to decrease the intracranial pressure or the intraspinal pressure. Other different medications are also commonly used to decrease the intracranial pressure, either intraoperatively or is also for some patient as outpatient. And I see quite a bit of Lasix and acetazolamide has been used for that. One more medication which is not in this list, which we use more commonly on headaches, and we have our own thinking, is topiramate. That is also has the altered secondary function of the reduced carbonase anhydrase inhibition action. So, and that is the reason we think it has helped in different headache. Not that sensitivity is not that great, but still, whenever it helps, that was main reason we think about that. But again, there are other medications which we use to other functions. The more commonly used medications which we see all the time of different neuropathic pain medication, which has anticonvulsant, antidepressants, and those are, I'm sure you must have come across with these names: gabapentin, pregabalin, topamax, which I already told. Carbamazepine, I think, is an old. It's the medication which is used very commonly for trigeminal neuralgia, and before all these medications came, this is very commonly used for all kind of nerve pain medications. So it's relatively, I don't use it anymore, even for trigeminal neuralgia, because of it requires quite a bit of monitoring and more toxicity associated with it. Antidepressant, again, this phenomena of amitriptyline and venlafaxine is coming from the old literature. We recognize there is no role in chronic pain. Only medication which has value, at least in chronic pain, is duloxetine and maybe milnacipran, which is the newer serotonergic and noradrenergic inhibitor. Again, there are several range of benefit associated with it. They are not that highly effective that everybody feels better. The success rate of these medications for chronic pain is around about 60%. What good part is they are not the same 60% for every medication. So that's the reason you see sometimes it's frustrating that people keep changing and keep moving on different medications on those. Local anesthetic is other thing we use because we do the injections and everything. Oral mexiletine is available. Very, very rarely people use oral mexiletine. It is used more commonly for arrhythmias, or very rarely. I use quite a bit because I see one end of one disease patient. That is the only medication which they respond to. But very rarely you will see that because of the toxic effect on the different analgesics, which is point of contention all the time. Opioid has never been shown that effective in a long-term use. Acute pain, acute situation, post-surgical symptoms, and acutely, wonderful medication. Because of so many different factors associated, and it is easy to say, but has not shown that much effectiveness in that. And then afterwards, cannabinoids, which is the newer addition of that. We, from University of Iowa Pain Clinic, does not support cannabinoids. For the reason is not that it is not effective, because of the data for the interaction with different medications are not out there. There is a first paper published after in I think 2023 January about the interaction with different polypharmacy. Unfortunately, chronic pain patients are on several different medications. That is the rationale we are using, because we don't know. Because as a physician, we first not do harm, and we follow the policy much more close to our heart. So when we move on interventional, there are multiple things we offer. Our clinic is neural blockade, cervical spine interventions, and neuromodulations. For the neural blockade, I have not done here, but in the past we used to do the scalp block. Essentially what we do is in diffuse headaches, we just block almost every nerve at the same time with a local anesthetic from supraorbital up to the occipital. Had shown good benefit, but short lasting. So not a great tool, at least for the chronic management of the headache in this group of patients. Botox is very varied, and I'm, again, not a big fan of it because of after some time we start seeing much more newer complications associated with it. I think that is mainly because of the capitis muscle relaxation happening because of when we are using the Botox on the neck component and causes more weakness. And we start getting more and more neck symptom afterwards. So for cervical interventions, again, if patient has neck pain, we have several different injections we approach depend on what we want to do. Atlanto-occipital joint injection, atlanto-axial joint injections. On that, we do the facet joint injections. Facet, we hardly ever do facet joint injection anymore because of steroid is not shown repetitive steroid exposure. So we start doing now radiofrequency ablation of those. So when I was talking about why we are interested upon the rectus capitis muscle, because and we as a definition, at least in our practice, we always pay attention on, so we always ask for the flexion extension view. If there is any listhesis, even slightest, especially upper 3 cervical vertebral body, if even the slightest 1 millimeter listhesis associated with the movement of flexion and extension view, we don't do the RFA. And now, after reading that paper, I feel like why those patients fails, I think we are making those capitis muscle weaker by doing those injections and created the more higher degree of listhesis. We also do the stellate ganglion block. On a POTS lecture, we are doing quite a bit of stellate ganglion block for the brain fog associated with those infections, especially post-COVID, with almost 60% success. So there are several different injections besides the epidural injections, which we had mentioned, that has had some potential to help. And some of the neck pain symptom, again, these are all the patients which we are talking about. They are either refractory or they are not surgical candidate up till now. So then we move to neuromodulation, which is actually, I think in my book, it has a much more bigger role. I'm not doing this. So the above cranial stimulations, but we have a faculty here who had done and I'm not sure because of the Chiari, but had shown good benefit from that. So essentially, it is what you have, neuromodulation is applying the electrical current to regulate the neural activity. And it also affects this modulating feedback loop to enhance the CNS plasticity for our betterment. It also affects the surrounding neural target tissues to accelerate functional recovery. It has shown in spinal cord injury patient that it's not just target, which we start doing in epidural space at C6, 7 or C5, 6, whichever it is. It is not that stimulation alone, but it's stimulation of the other surrounding neural tissue accelerate the functional recovery. Not only motor, it is also autonomic recovery associated with that. Of course, pain signals are reduced. That's the original reason of start doing the neuromodulation in pain thing. There is especially the peripheral nerve stimulation the data start coming out strongly to decrease the peripheral inflammatory response. That is where the cascade start for chronic pain component to create the peripheral sensitization and lead to central sensitization. And also shown in spinal cord injury, they promote neural regeneration, especially when there is a partial nerve damage. So there is significant research is coming on this side. Again, they are still not the panacea to find out. Again, these pictorials are just for the reference, but again, that how the above cranial stimulation has shown what mechanism is. Again, I don't want to go into that detail, except for the benefit on that. So essentially, the purpose of using different tools are symptomatic pain management. This is the prime component for us. Neurorehabilitation is extremely important, and improved functional quality of life. They are invasive or non-invasive. Invasive is the peripheral nerve stimulation. I put occipital because of it is more commonly used in the Chiari. Targeted nerve stimulation of any specific nerve, like supraorbital or infraorbital, whichever, if a specific nerve is there. There is a subcutaneous field stimulation. So if it's a diffuse pain and you don't have a neural target, or you cannot reach a neural target, but it is not that deep, even the placement of the stimulator, the subcutaneous field, even up to 5 inches apart, can create a significant benefit for that patient. Again, its research is still working on it to get enough data to get the insurance approval on that. Spinal cord stimulation, almost everybody knows that we put the lead inside the spine. To get the benefit, and deep brain stimulation, which is the intracranial, where you put the invasive component. There are non-invasive component, which is repetitive transcranial magnetic stimulation, RTMS. It is approved indication. It is come with the name of Cephali for the headaches, for migraine, but not. I had used only one of the Chiari patient on that because, again, approval. At least that patient did not respond. So it's my personal experience of N of 1 of using RTMS on Chiari headache had not shown much benefit. We use TENS pretty commonly, maybe not because TENS cannot be placed where there is no flesh of muscle in between the bone and the skin. If you do that, it can cause the hyperneural stimulation and cause significant pain. So in Chiari, we cannot use it over the skull area, but we use it over the neck. That has shown some benefit on if there is a primarily posterior headaches. Transcranial direct current stimulation. Again, various techniques has been used, or all these are done. How much evidence is there? It is still up in air. It's not that, not too many studies is published on those. So, now so we know that it's not panacea. So we don't have that great success with that alone. So now the newer dab on the research and use different modalities put together, and had some of the research is coming on that. And the purpose of that, so we use the term multimodal neuromodulation, where you use different modalities to do. So essentially, it is the mechanical summation to cause interfering pain signals, modulating the affective component of pain, which is also, we talk about biopsychosocial component that has shown benefit, modulating neuroplasticity better. We can specifically target the specific structure in 2 different modalities, because one modality is cannot be done, or that area is not accessible with one modality, but you can use the other one. Enhancing the endogenous pain inhibition, that has been again shown enough evidence for that. So, but if you use 2 modalities, that can be effect. And now, because of the new research with the anti-inflammatory effect and blocking the peripheral sensitization, now use of central stimulator with the peripheral stimulator has shown picking up ground in several chronic pain issues. There are several examples. These are the modalities. At least 1 case or 2 cases has been reported. Use of optogenetics, where the electrical light, so that they use the virus, which is sensitive to the color of light to stimulate the neural tissue, with the regular electric neuromodulation has coming up to the benefit, shown some benefit. Again, using a virtual reality along with that stimulation, what that means is people are using their environment also to affect their improvement in the relationship and come up with the better pain control. Chemical neuromodulation, it may be not appropriate for this patient group, but using the medications to modulate the spinal signals, intrathecal placement of different medications, clonidine, even sometimes opioid, or so many other different agents has been used. And in some of the group start showing better results. magnetic stimulation, this is that electrical stimulation for stroke patient associated with the RTMS had one or two reports come out with the better results. Spinal cord and peripheral nervous stimulation, which I already talked about because of this is coming mainly from spinal cord injury, and the group from San Diego is working, VA of San Diego is coming up with this modality quite a bit. Stem cell therapy, along with the neurostimulation, it has shown better results from the stem cell component and some of the neural regeneration. Use of TENS, use of closed loop system, that it is creating a biofeedback in itself, not biofeedback, the feedback loop to itself to make this electrical stimulation more patient directive or to be more acceptable to the patient. Very early part of that was available in the spinal cord stimulation with the gyrometer inside the battery, where the position change was recognized and the intensity was adjusted, so patient is not getting frustrated and they don't need to keep bringing out this remote to adjust their energy. But now the closed loop system is even becoming more and more robust on that. So this is a newer component which is already in use in humans. The advantages significantly, better pain management, of course, reducing use of medication, because either in long-term use, every single medication causes side effect, so we don't want to use that long-term. Again, associated morbidity limitations because of so many patients with that, say, most common is renal failure, which we cannot use so many different medications, so that is an option. It can be tailored and customizable, different modalities to the patient. Now we are enlarging the spectrum and horizon on which patients we can use, with earlier we were not even to give any options. Again, refractory symptoms can be tackled. By this, because of this closed loop feedback mechanism, now we are empowering the patient. And so whatever their contextual fluctuations are, they work like mechanics, they work under the car, they are bending their spine in a different way, and they require different energy distribution at different level, different position. That is one thing, which is, other thing is feedback is given directly to the system to even change not intensity, change the different parameters. That is the pulse width and the frequency also. It is associated with the fewer side effects, minimally invasive, of course. There is no physical or anatomical alterations are happening, so it is kind of reversible. If it doesn't work, you can take it out. Yes, there is a scar if invasive mode has been doing. It improves quality of life. There is long-term benefit because of, at least in pain management, we have seen when we start moving more on the neuromodulation, especially in my lifetime. When I started, it is not that commonly used, but now it is commonly used. We are starting using less intervention. This patient doesn't go through with those painful procedures. And of course, that helps in the long-term cost effectiveness. So I think this is where at this point, this is also not perfect, but at least we are moving forward on that. And we have shown that benefit. Physical therapy and lifestyle changes cannot take it out on that. Purpose, multiple fold, of course, symptomatic pain management, improve quality of life, or either improving functioning, strengthening the musculoskeletal system, improve balance through the posture correction, and by doing all this, protection of the further insult. So for physical therapy itself is just a gentle stretching exercise to increase range of motion, but the lifestyle changes are significantly important, that we want to enhance the good habits, which is this proper sleep behavior and the relaxation activities. It has indirectly shown the endorphin intensity with the relaxed person is much more effective for the pain relief in comparison to people who are sleep deprived or stressed behavior. Of course, ergonomic adjustment, as we talk about our patient, which we talked before, but most common is, I think it's, at least in our university, it is available, that ergonomic adjustment at the computer desk and chairs, even that's the first start. We should, especially in this group of patients, when there is a stenosis of the scar at the level of brainstem. Try to avoid neck traction, manipulation. Try to avoid traumatic activities with the zaring effect at that level, especially the contact sport, roller coaster. I had a patient who got paralyzed, actually, who known patient for Chiari, and she was warned by surgeon, and she went to Six Flags, and somehow the roller coaster effect, she got almost start getting all kind of symptoms, and in 3 days she was paralyzed. But so it's not that I want to put the fear, but I think that tells us to make sure that we tell our patient that there is a very possible situation. Of course, every person is much more different in spectrum, how much problem they have or how much stenosis they have, but it is always possible. And avoid extreme repetitive overhead activities. Also, we want to, for us at least, as a pain specialist, I always make sure that patients should know they should be cautioned for any spinal injection and the proper positioning during the sleep, because of if they were not taught, they will sleep with a hyperextended neck and can cause more issues. They wake up with more problems. And of course, if there is a balancing issue, then so this is extremely important. These are the situation which had happened because of either patient didn't know or we failed to educate that. And there is multiple reasons why exercise can help in pain by, of course, increasing the brain volume and activity and cortical thickness. And that has, if you go back into the chronic pain suggested changes of the brain, that is actually partial reversal of that and can improve on the pain component. So other non-pharmacological studies, again, psychological modality is extremely important because we talk about the stress is not the best thing. There are multiple psychological modalities that are available, especially the mind-body therapies, the acceptance and commitment therapy, because people should not be feeling that we need to taught them to accept the situation, that it is there, but they can still do their activity. So towards the value-driven actions to manage more frustration than pain, essentially. So it can create the better, meaningful living. Cognitive therapy is a little different, in which you challenge their negative thoughts and try to change the behavior according to this. It is much harder. You cannot change that easily, but again, some patients, with the persistence, we has enough success with it. Now the guided imagery, which was before this virtual reality business, that when the directed thoughts and visualization of relaxation and calmness reduce the stress, had shown benefit. There is a mindful meditation, which is whichever the way you are choosing, yoga, tai chi, so many different modalities are available, where mind to focus is focused towards the attention, towards the positive thing through the physiological mechanism, either is a regular breathing or doing certain positive activities which can be help to detach from reflexive negative thoughts and behavior. So these are the older generation component. I would not say older, it's still relevant. Now the invention or introduction of the virtual reality, or now even mixed reality, the VR virtual reality basis guided imagery had shown significant benefit in certain patient group. Although it takes some time to get used to it, because of anybody who had used this modality, in the beginning you can get dizzy with that, but you can get used to it. Acupuncture, some of the data is there to show the muscular relaxation, musculoskeletal relaxation, but it is not like that. Data is not that strong, unfortunately. But again, when you are not having other benefit, this is one modality used. So over the years, I used to give this quote to my patient to empower them. And I didn't know that from where it is coming. And when I was preparing this lecture, somehow, and I put, there is a Chiari Malformation patient awareness group which uses their motto, very strong component of this. And I always tell that they whisper to her, "You cannot withstand the strong." She whispered back, "I am the strong." So if you empower the patient, they can better control their life for a better, meaningful situation. So again, we cannot overlook that, especially in chronic pain. We don't do that. So I don't know the association, but I like this because this is the quote I used to use for almost 20 years to my patients, but now I find out that this. So of course, it is the self-advocation and the better community citizen we can be, because of if you know something, you can help others. Shared decision-making, because of you are taught about that. So you are helped in your own betterment in the shared decision. You are more open to the lifestyle modifications. I don't know, we come across, especially for the back pain patient, because of the symbol associated, whenever we said, okay, yes, you are 25-year-old, but you should use cane to prevent fall. And they laugh on us, and the first thing is, no, I'm not old. I have my social presence. I will not use it. Again, that is, I can understand. And then when they have the accident, they fall, and then, okay, can you give me the prescription? But this is a routine thing we see. But I think when they are more educated, they improve their treatment adherence, of course. In that situation, they get the better long-term component and better emotional and psychological well-being. So this is what the multimodal component. Now we go back to our patient, which we talk about. It started when she was 19-year-old. Now, fast forward after that good benefit from the occipital nerve stimulator bilateral, significant in 4 years, although overall she was significantly beneficial, she was doing fine. One day she shows up again on my clinic with the diminished stimulation and recurrence of headaches of similar nature of before the stimulator. So at this point, we decide to revise the stimulator. And again, we got significant response. It's a people who don't know the occipital stimulator component, it's a much more complex component because of we put the incision, we are making almost 90-degree bend on that lead to put on both sides. We need to cover it up to the mastoid because we want to cover the lesser occipital component along with the greater occipital. So the lead now there is one company which makes with the lead of 16 electrodes, but its length is not enough. So some people had tried to put it from one side and go on the other side, one lead, but then they don't have the full coverage. So I am not part of that group. I prefer to put the lead in the middle, and then one goes the other side, another one goes the other side. This is the actual picture of that patient, so I will talk about what. So again, she got great. She went back. 4, 5, 6 years later, she come back by the time I moved here. So she found me again because of, she tried to convince so many people not, and people are not interested to do that. The problem with her was, she already had the Chiari decompression. She had the scar, which was not developed keloid, but she was having very thick scar, and still some activity. So the first time the stimulation was diminished, I didn't take out the system. What I did is I just, we agreed that because she understood what we do. So I took out all leads only up to here. I didn't even do that. So right where it is making a bend, and transposed under the ultrasound, a little bit below that scar, and she got the benefit again. So that was the scar formation around this leads before. So again, she has now returning of the left-sided headache. Again, choking comes back. She does not feel anything on the left side. So we find the electrodes are broken, malfunction, and decision was made to replace the lead, both of them. Again, because of the new state, new component, it took way long to get this process. In this time period, she stopped using it. What we find out after this is she didn't have any symptom left over after this 10 years of experience on the right side. Only the left side is our problem now. So I have very good long discussion. If I need to take the whole system out, it is a much more bigger surgery. Instead of, as the right-sided lead is not happening anywhere, not doing anything, why not I just take the right lead out? Left lead is broken anyway, but I cannot take it out because of, I just put and she agrees, let's try that. And we did that. I talked to her a few months ago. She was still doing very well on that. So Again, this is where we always do out-of-the-box thinking. I don't think so any case has been reported ever to transposition the lead and you get the better. But so it's a success story, significant success story. Her main issue was it's 10 years later when she come back, she has a difficulty in swallowing, so she was losing weight because she cannot eat too much. And so that's a significant concern for her. So again, this is what I have for all of you. It is a complex problem, but we need to think out of the box, use the tools whichever is available to our best on that. Any question? I think we will talk later. Yeah, great. Yeah,
Thank you.